Next, I'd like to introduce Kristina Rod. She's a pulmonary and critical care physician and a researcher at the University of Pittsburgh, and her expertise is particularly around sepsis epidemiology, and she'll be talking about that subject with us next. Thank you, Kristina.
Thank you so much, Saul, and thank you so much for the opportunity to speak today. Next slide. I have no financial disclosures to report. Next. I feel it's really critical from the outset to remind ourselves that sepsis risk is impacted by far more than an individual's comorbidities or their immune response to acute infection. And while we frequently focus on these individual features, particularly when we're discussing things like diagnostics, it's important to keep in mind that all of these layers, really all the way up to societal forces, ultimately impact an individual's risk for sepsis. Next slide. I'm going to begin today by sharing some major sepsis epidemiologic trends on a global level, and then focus specifically on the United States. The global data I'm going to show comes from the IHME sepsis study, which I was privileged to help lead and was published earlier this year. Next slide. We estimate that there are just shy of 50 million incident cases of sepsis worldwide each year as of 2017. Next. And 11 million deaths. This represents approximately 20% of all global deaths in 2017. Next slide. The incidence of sepsis varies substantially by location, with age-standardized rates per 100,000 population varying as much as 20-fold across this map that you're seeing in front of you. Next slide. I'll give you a few examples. So the United States has a rate of approximately 250 cases per 100,000 population. Next, Brazil, 450. And next, the Central African Republic, on the next slide, which has a rate of over 2,000 cases per 100,000 population. This is the highest incidence rate in the world. And as you can see, sepsis incidence goes up in general as healthcare access and quality goes down. Next slide. When we look at the percentage of all deaths in a given location that are related to sepsis, you can again see really large differences, with over half of all deaths that are actually related to sepsis in some sub-Saharan African countries. Next. Also, when we look at the underlying causes of sepsis, we know that sepsis is, of course, always caused by an acute infection that sets off this dysregulated host immune response that Dr. Shankar-Hari discussed. But oftentimes, and in fact, in over 50% of cases in some locations, there's a further underlying non-communicable disease or an injury that directly led to acquisition of that acute infection. So this might be something like lung cancer that caused obstruction and a post-obstructive pneumonia that went on to develop sepsis. And this was actually something that was really novel in the IHME sepsis study, that we were able to identify just how common it is that somebody has a non-infectious underlying cause. Next slide. When we look at what those causes are and really kind of dive into what those things are, this figure is just to give you a flavor. I know it's a bit small to show, but these are the top 20 causes of sepsis-related deaths in 1990, 2007, and 2017. And while pneumonia is the most common cause of sepsis in every year from 1990 through 2017, things like neonatal disorders, stroke, cirrhosis, COPD, diabetes, chronic kidney disease are up there on the list in nearly every year. Next slide. So I now want to focus on the United States. Chanu Rhee and colleagues published one of the major recent papers on U.S. sepsis epidemiology, which for the first time in a national estimate used an electronic health record-based approach to estimate sepsis incidence and mortality. The IHME sepsis studies estimates for the United States were somewhat lower, but were similar overall. And I presented the IHME sepsis study estimates for adults as the lower bounds in these ranges in the slides, and the re-study is that upper bound. Overall, our study estimated that there are approximately 1.1 million sepsis incident cases each year in the United States among all ages, and just shy of 200,000 deaths as of 2017. It's really important to remember that while sepsis is a major public health problem across the United States, there's strong evidence that certain subgroups are at far higher risk than others, with higher incidence among neonates, older adults, people with multiple comorbidities, and those in communities with lower healthcare access and quality. So these risk factors are closely linked to one another and are geographically clustered, as I'll show you. Next slide. So Dr. Angus and colleagues have led previous studies detailing how the sepsis burden in the United States breaks down by age. This figure, which is from a major study of pediatric sepsis epidemiology in the U.S., was led by Scott Watson and Dr. Angus, demonstrates that similar to the findings of the IHME sepsis study, which I didn't show you, pediatric sepsis incidence is highest by far in the youngest age groups, so especially neonates. I'll note the break in the y-axis here. So incidence in children less than 1 year old is over 10 times as high as the next highest age group among children. Dr. Watson's study also found a male predominance. Boys are in the white bars here and girls are in the gray bars. And although this was not identified in my work with IHME, several other US-based studies have borne out the similar finding of a predominance among males. Next slide. Also, while the IHME study found that neonates have the highest sepsis incidence globally, and indeed do have the highest rates among children in the United States, other U.S. specific work performed by Dr. Angus and others has demonstrated a strongly positive relationship between age and sepsis incidence rates, as well as case fatality rates. So here you can see as we move across that x-axis from neonates on the far left to those who are 85 years and older on the far right, that both sepsis incidence and case fatality rates rise substantially. And actually my work has found that more than half of U.S. sepsis deaths occur among adults who are 65 years and older. Next slide. The relationship between sepsis and features of aging, including frailty and inflammation, has been very well described. This study by Dr. Shannon Fernando demonstrated that among 1,500 patients aged 65 years and older who were admitted to an intensive care unit with suspected infection, frailty was strongly associated with poor outcome, including much higher rates of in-hospital mortality, longer ICU and total hospital length of stay, higher proportion of patients who were discharged to long-term care facilities, and higher rates of readmission to the hospital within 30 days. Additionally, there's increasing evidence suggesting that inflammaging, which is the syndrome of chronic low-level inflammation that characterizes many features of aging, may have important health implications, though its direct relationship with sepsis has not yet been described. Multimorbidity, which is the accumulation of multiple chronic diseases over time in an individual, is a key predictor of sepsis, irrespective of social factors. In this really innovative study, Dr. Beck and colleagues used electronic health record data covering all hospital encounters in Denmark over an 18-year time period. So this included over 6 million patients. And they found that patients who followed these recurrent trajectories of time-ordered accumulation of comorbidities had significantly increased sepsis mortality compared to those who did not follow that trajectory. So this network was constructed from 56 kind of individual sepsis trajectories, and it illustrates kind of simultaneously the number of patients who receive a particular diagnosis like hypertension or diabetes and the increased risk of dying from sepsis within 30 days from these different trajectories. And of note, major starting points, so that first diagnosis that sets off this cascade of accumulated chronic comorbidities is often alcohol abuse, diabetes, or cardiovascular disease, again, in this set of patients from Denmark. Next slide. Sorry, I forgot to advance. So next slide again, please. Thank you. Sepsis clusters geographically in medically underserved areas. In this study by Dr. Wang and colleagues, state-level sepsis mortality rates varied more than twofold between states. And a cluster, as you can see, that extends from the southeastern to the mid-Atlantic U.S. Encompass states with the highest sepsis mortality. Some have termed this area our country's sepsis belt. Also, individual level social factors such as race or racism and poverty drive many of these disparities, but not all. So, for example, one study by Andrew Goodwin and colleagues found that using administrative data from all non-federal hospitals in South Carolina, residents of medically underserved areas were admitted more frequently with sepsis and were more likely to die of sepsis, even after adjusting for age, race, and severity of illness. Next slide. In addition to healthcare access and quality, income level, race, education, insurance status, and marital status have all been shown to be associated with sepsis incidence or mortality in the United States. For example, multiple studies have found increased sepsis risk among Black Americans versus white Americans. This study by Jordan Kemker and colleagues found a twofold increased age and sex-adjusted risk for sepsis death among Black Americans, which was higher than the adjusted risk for other causes of death. So there's something special about sepsis in this case. This figure from their paper shows comparisons of covariates proportional mediation of these Black-white disparities for sepsis using data from the National Health Interview Survey. So this is conceptualized as the relative amount of the total age and sex-adjusted Black-white disparity, which is accounted for by each specific variable listed here along the y-axis. As you can see, economic factors and education levels were among the strongest mediators of this relationship. Next slide. In conclusion, there are significant disparities in sepsis incidence and mortality by location and by healthcare access and quality. Neonates are among the highest risk age groups, both in the United States and worldwide. Among adults in the United States, we know that aging, frailty, and multimorbidity are major risk factors for sepsis. Over half of all sepsis-related deaths are among patients with an underlying chronic disease or injury that directly led to their sepsis incident. And social disparities are strongly linked to sepsis incidence as well as mortality. Thank you.
Kristina, thank you very much. That was excellent. I'm going to go off program for a minute and ask you a follow-up question, taking the prerogative of the chair, realizing that we'll all come back in a few minutes to have a more lengthy conversation. I was struck by the similarities between the incidence of sepsis and what I know from research on patient safety, where it turns out in the patient safety world, almost everybody is vulnerable to harm. But those who have multiple comorbidities, those who have less physiologic reserves, those at the extremes of age, those are most likely to get into trouble, to have adverse outcomes associated with the infection. You seem to suggest that it's actually more complicated than that. And I wonder if you wanted to comment maybe on the difference between incidence and impact of sepsis diagnosis.
Yeah, I think that's a really great point, Saul. I think that's probably part of it, is that those that have kind of the least reserve are at highest risk. And certainly we see that with frailty. But I do think that there is evidence suggesting things like dysregulated host immune response is more pronounced, particularly in older adults. So I have a particular interest in kind of that trend because it is such a massive proportion of our sepsis cases and our sepsis deaths, frankly, in the United States. And so some folks have done really nice work, for example, showing that elevated levels of certain immune kind of pro-inflammatory biomarkers, even years before a sepsis diagnosis, portend worse outcome. I think that's really interesting. I also think that there's potentially something to epigenetics when we start thinking about some of these social risk factors. I am not a geneticist, and so I won't get into the detail of that biology, but I think there's actually a growing literature showing that social environment and accumulation of comorbidities does impact epigenetics, and perhaps that might also be mediating kind of host immune response to that acute infection.
You anticipated my follow-up question, which is about whether there might be some differential susceptibility in ways that we can't measure. I have one last thing before we move on, which is I was interested in understanding, certainly in the diagnostic literature, when we think about delayed diagnosis of cancer, that it's often due to challenges with access and literacy. And I wondered if you have any thoughts or information about how that might apply.
That's a great question. Access, absolutely. There's some great science by Chris Seymour and others recently that have been looking at how state-level health policy around sepsis impacts sepsis care and sepsis outcomes, particularly in New York State, which has really kind of led the way in health policy solutions to sepsis in the United States. And I do think that healthcare access and quality is absolutely essential. When I showed you those maps from our IHME sepsis study, those color kind of disparities track. If I were to show you a map of healthcare access and quality worldwide that had nothing to do with sepsis, the maps would look nearly identical. And that's probably not only about patients that are, once they have sepsis, how quickly they can get care, how quickly they can get an accurate diagnosis of what's going on and appropriate treatment. But I think it also is about prevention of sepsis to begin with. If you don't have access to high quality primary care and physicians, that are very high quality and are taking the time and have the time to do an excellent physical exam, like Dr. Verghese, mentioned, if you don't have access to that, your diabetes is going to go unchecked. Your hypertension is going to be out of control. You're going to get wounds on your feet. You're going to be at risk for developing infections through those wounds. And so I do think that healthcare access and quality is absolutely essential through that whole continuum of prevention, identification, accurate diagnosis, and then treatment of that sepsis to prevent mortality.
Thank you. So a public health approach is part of our prescription.
That is my song.
Very helpful. Thank you very much.